Hi, good afternoon, everyone, and thank you for attending this session of Grand Rounds. I'd like to welcome our presenter for today, Dr. Erin Calhoun, who will be presenting on simulation and infection control. At this time, I'm going to stop sharing my screen and turn the presentation over to Dr. Calhoun.
Thank you very much. Can you all hear me?
We can hear you.
Okay, excellent. Let me just get the screen going. This talk I'm going to give is going to focus a lot on sort of the basics of healthcare simulation. And at the end, I'm going to get into some potential applications that it has to infection prevention. But I really felt like as a simulation expert, I would most help this group if I focused very specifically on exactly what can and cannot be done and provided some of the evidence for that. So just to kind of get going here, we're going to be talking about, there we go, the art and science of conducting healthcare simulation, and I'll add with an eye towards infection prevention. Just to go over the obligatory disclosures, I do receive honoraria from the Society for Simulation in Healthcare, where I serve both in a leadership role and as the Associate Editor-in-Chief of the Journal of Simulation in Healthcare. So first, we're going to talk a bit about adult education theory, or then we're going to talk about 4 standard models of simulation, going from the ones that perhaps you might be the most familiar with, maybe from time having done these, to ones that are really focused on rapid skill acquisition that is done at the bedside. We'll focus on that more and more. And then finally, I'm hoping to just mention some ideas on simulation and infection prevention, and then open it up and see what thoughts the team and the group has. So first of all, what are the educational approaches we actually use when conducting healthcare simulations? Well, there are many different adult education theories. Just for a bit of definition, adult education is based on the idea that, adults are not just large children, and adults really tend to learn based on experiences they have had or problems they currently face or issues that have sort of disrupted the flow of their work or lives in time past that can prompt people to begin to look for new material, new and interesting ways of understanding or theorizing about that, applying that, and the cycle continues. So this model was developed by David Kolb, I believe, in the late 70s. And in his view, adult education really begins with having a concrete experience. This could be anything from, say, a code that doesn't go well, going to my sort of native idiom of pediatric critical care, or perhaps in the infection prevention domain, it could go towards outbreak of central line infections, a concrete experience that you have to deal with. This then leads to a period of reflective observation where you're observing, gathering data, thinking about the experience, processing it, trying to sort of get your mind wrapped around it more or less. That then leads to a time of abstract conceptualization where you basically draw conclusions. You create a model. You come up with something that you believe is a good understanding of that experience. But in the adult education cycle, it does not end there. It then goes to a phase of active experimentation where you actually try something out new, where you apply that in the real world, which leads again to a new concrete experience, and the cycle begins again. If those of you that are familiar with the PDSA cycle, you might see some similarities here. I don't think that is coincidental, because they are also ways of iterative improvement. But the key is where can simulation really work to impact this? Simulation, not just as a means of teaching, but as an overall method of approaching situations in healthcare. And so 2 key factors in simulation are the simulation proper, where you enter into some type of simulated environment. This could be in the simulation center. This could be, it's the 21st century now, it could be virtual reality. It could be a distance learning environment. It could be in situ simulation, which is an area of research of mine, where you actually deploy the simulated experience within the hospital itself to test real systems. But either way, the simulation proper both allows for members of the team to have a concrete experience of some clinical event, and it also provides a place where active experimentation can happen in a safe manner. In simulation, no matter what happens, nobody gets hurt. This is a principle that I really try to drive home when I do training with residents or fellows or nurses, is that you're free to fail. I don't even like using that word, but you're free to make mistakes. I would rather people make a mistake in good faith in a simulated environment and learn what to do correctly in the real world than make that mistake on a real patient. So I even define, when I begin to open these environments up, I think it's important to define something that might be perceived as a failure as a success if it changes real practice. But that aside, simulation really allows for experimentation and concrete experience. Debriefing is a time of extended reflection, or sometimes extended, I should say, on the simulated event itself, and a time where the team can discuss with a facilitator and sort of a model in the mind of what to do next time can be built. So the goal here is to show how simulation coupled with debriefing, these things go hand in hand, can provide an environment both for learning and also an environment for active experimentation of new techniques that otherwise you might only have to be able to apply to a clinical environment. So the next thing we're going to do is talk about a few different structures of simulation, going from maybe the ones you might be more experienced with to some other models that enable basically different things to be accomplished. So first of all, this is what I would call a simulation with reflective debriefing structure. If any of you have taken part in a simulation, as I've said before, this is probably statistically the most likely kind you've done. This was one of the first models made. And in this way of approaching it, you have a pre-briefing. Pre-briefing is basically a brief informational session for participants where you go over some of the ground rules of the game, how the mannequin works, what will or will not be available to you in the environment, who you can call, who you can't call, and also the establishment of something called a fiction contract. Well, that's kind of a somewhat fancy psychological term. It basically is the same kind of thing that you do when you go to see a movie. You know for a fact that what you're seeing on the screen is not actually real. It's filmed, it's staged. But for the sake of enjoyment, in the case of a movie, you're buying into an as if. You're going to treat what's happening and what you're viewing as if it's really happening. And in return, you get entertainment, maybe some new insights, or whatever reason you went to the movie. And simulation is no different. It is a fictional situation, but it is a fictional situation designed to represent something real. And so in the pre-briefing, we gather the input of the team and we establish a fiction contract where we acknowledge that what we're portraying is artificial, but the team acknowledges that they acknowledge that and makes a commitment to us to try to buy into it as much as possible. Without that, learning really can't happen. This structure next phases into the simulation session proper, lasts, for the ones I do, typically about 20 minutes, but this is where you're actually in the simulated environment, engaging with the mannequin or the actor, or sometimes a combination of the two, engaging with your teammates, going through an actual case. And in this model of simulation, this is ideally uninterrupted. The goal with this structure is immersion. You're trying to get people immersed into an environment, believing that it's as real as it can be. You're trying to tell them a story that they feel a part of. And you essentially don't really give them an opportunity to come up and discuss in any kind of a meta sense until you hit the debriefing. Now you'll notice the debriefing, which is last, is set at about the same time length as the pre-briefing in the session proper. And that's because in these extended debriefings, the goal is to really unpack everything that happened within the simulation itself. And so they can take a while and you have to leave enough time for it. There are many, next slide here. Lost my mouse. There we go. So this just kind of goes over the ideas that we've already talked about the fiction contract. There's also a need to discuss fidelity in that pre-briefing. What is fidelity? Well, fidelity is a multifaceted concept that talks about how realistic the mannequin is, how realistic the environment itself is. This is especially relevant if you're doing the simulations in situ in a hospital, because in that you're actually using the real environment. So it's really truly the highest fidelity possible. But also the nature of the team you're with, the social fidelity, and the fidelity of the case. Does this case make sense? Is it the kind of thing that you would normally encounter? Could you see this happening in your practice earlier? And so going over all this is really important, again, for that educational outcome. Mentioned this, and now we'll talk a bit about another variant on simulation. So we have found in our program that prior model works well with teams of highly experienced or moderately experienced individuals. Individuals who, when you present them with a situation that you're simulating, really can sort of just kind of go. They can be expected to be able to manage that kind of situation or situations of at least that degree of intensity or complexity. And so you are kind of within a reasonable boundary by saying, we're going to just simulate for 20 minutes, do what you would do in real life. We're not going to come up for air at all. But for newer learners, or maybe even more to the point, learners very inexperienced in the matter that you're teaching, there is another model that one can employ called simulation with micro-debriefing. And I've tried to represent that here by showing the typical pre-briefing, which would go the same way, but then the idea that the simulation session itself runs over a longer period of time with debriefing sort of interspersed into the session at various key elements. So again, the typical approach for a lengthy reflective debriefing is a very long, kind of drawn out process. And we're gonna go into what's needed and used in that process in a few moments. But micro debriefing is basically a pause and reflect. And where that pause and reflect happens depends on the situation the learners are encountering. So you could imagine if you had a team of learners doing a complex situation that are very novice, they might run into a problem that you realize partial way through the sim, they simply have no ability to navigate. They're just going to stand there and look at the mannequin and just be scared. And so rather than force them to kind of walk through it when you know that you're kind of moving in that direction, this allows you to redirect and say, you know what, let's pause now, let's debrief. Time to ask your questions, time for me to probe and see what you're thinking about what's going on, and then allow you to either replay a part of the sim or just jump back in. And the choice really depends on educational goals and really mostly the learner group. So as I said before, the reflective debriefing approach is best with most experienced learner groups that have at least some degree of knowledge of the subject matter. And the goal of this is to really focus on higher level interactions. It's really hard to watch teamwork, say, unfold if you're stopping every 5 minutes to give advice. And it really creates a more immersive experience. The more you make people behave as if they're in that real environment and don't let them step out of the role, the more they buy into it and the more they kind of get emotionally activated by the situation that's happening before them. And it does allow for higher learner stress levels, which is not always a bad thing. Stress has been shown to assist with learning and assist with retention. And so these are typically higher stress situations. Micro debriefing, again, novice learner groups, lack of knowledge of the subject matter, focusing on more granular skills, and then allowing for mid-course corrections during the case. And really, this is a way to de-stress, to remove stress from the learners so they can focus on learning micro skills that they might not have had the capacity to do. So I think a great example of this from my own, my own field, would be bag mask ventilation. It's a core skill. It's very important, fundamental to a lot of interactions, and it can be difficult to learn. And so if I have a novice learner group and it becomes clear to me, again, using this model of simulation, we're 10 minutes in and it's just clear to me that they can't bag the patient. There's no way they can successfully navigate the situation without being able to have the skill. It would be better at this point to say, you know what, I'm going to transition to this pause and debrief mode so that we can go through some of these skills, teach that in the moment, and then allow them to go back into the situation armed with that knowledge. And you might only need one micro debriefing for that skill, but typically if you're missing one skill, you might be missing a few of them. So this can be a dynamic change. So debriefing itself, how do you conduct it? This is also an area that many people just starting in the field of simulation struggle with. And so there are two techniques that I'd really kind of like to impress on the group that can be very useful. One of which is called a plus delta. This is pretty simple. This is just identifying team strengths, again, asking questions to have the team identify their own strengths and having them identify things they might do differently next time. This is why it's called plus delta, not plus minus. The goal is not to, the goal here is not to overtly state that the team is weak at something, but recognize that people are there to improve, to fill in gaps, to move forward in their understanding of a situation. Weakness sometimes can be seen as implying that the team is simply not good at that, when in fact, it's just simply something they might want to do differently later. And so this is looked at what I would do the same and what I would do different. It's a very easy, straightforward way to enter into a debriefing mode. The more complex technique is one called Advocacy Inquiry. It's the one I use most often. But this, I think, is vital, and it's vital for all kinds of education and non-education related sim work, because it enables the debriefer to get at frames of reference. So in the Advocacy Inquiry model, everybody in that room and the team itself to some extent has a frame of reference that has the knowledge base they've brought in, the skill set that they've brought in. It has their outlook on the world, their way of thinking about the problems that you're seeing. This leads in the simulated environment to actions, and those actions lead to results in the mannequin and in the situation. And so what this model does is it talks about how you reflect on these events. And so debriefing is often conceived as best done when asking questions. The first mistake debriefers can do is simply to walk in the room and say, here's all the things you did that I liked, here's all the things you would do differently. People might take away a point or two, but there's no real reflection there. What this model does is it encourages observations followed by questions. So I noticed that your team, noting an action, did not give the appropriate medication for this dysrhythmia. Name your medication. The result of that is the dysrhythmia persisted and we had to eventually initiate CPR. So I've acknowledged that an action occurred that led to a result. Doing it neutrally, just saying this led to that. Then the question comes with this greater loop on the outside. Can you talk to me about what thought process you had that led you to choose that particular medication? So when you take this approach, you're not just saying, don't do this. You're saying, I saw you do something that resulted in an outcome. I'm more interested in your thought process behind that than the event itself. And the reason for that is that frames of reference that are incomplete or that have incorrect information in them can often lead to more than just one error. And so by debriefing the frame, by questioning the frame, by having individuals discuss their thought process, you actually kind of confer upon the team the capacity to not just avoid the error you observed, you confer on the team the capacity to possibly head 10 or even 20 errors off at the past that could have moved forward from that frame of reference. So for the example that I gave, let's say that the frame of reference is, well, somebody in the room said to give this medicine and they were in authority over me and I didn't know how to challenge them. And so I just went ahead and did it. So as you might see, if the issue is not, I didn't know how the med worked, but I don't know how to challenge people that might be sort of above me in the hierarchy, but have simply are stating to give the wrong answer, that could actually make that individual make a number of different errors based on an inability to speak up, an inability to appropriately push questions and concerns up the hierarchy. So by getting at that, you can then give them techniques to do that, that will be more, have a higher degree of impact on how those individuals interact in future environments. So this gives you a sense of sort of that initial frame, that initial model of reflective debriefing with maybe a micro component. But more to the point for things like infection prevention, there are another couple evolutions of simulation practice, rapid cycle deliberate practice, mastery learning, just-in-time training, that have actually, they're more than variations on this. They kind of shift how the whole thing works in a way that enables you to really hone down on specific skills and give inoculation, essentially booster updates of those skills right as one needs to do it. And this, I think, has a lot of applications for your particular domain. So let's go over what these are. Rapid cycle deliberate practice, you can kind of think of it as a do-over. Starts again with a pre-briefing. It's important to establish all those things, but you do it quicker. And at first you might think this is like micro-debriefing, but in fact, it's not. What happens here is that you do the pre-briefing, you go into the simulation. It's a short session designed to last maybe 5 or 10 minutes. Then you debrief. But then after the debrief, if there are any skills that need to be done again, any skills that there were issues with, you then reenact the same situation and give them basically a second round of practice. So the goal here is that not only do you engage in a clinical event, debrief on that clinical event, so hopefully you've had some chance to reflect on it, but you don't just simply leave the room and hope that reflection's enough. You get to apply what you learned, cement the learning, apply those skills again, and then re-debrief so that ideally you can capitalize on the capacity to make a change in the moment. This is a very learner-centered instructional design strategy. And it really helps when specific performance gaps can be identified that need targeted feedback. It works very well for specific skills. It's hard to do RCDP with sort of global concepts like teamwork or leadership. Works very well for certain leadership behaviors like reorienting the team, or in an infectious disease prevention context for, say, something as simple as appropriate hand washing technique or appropriate sterile technique for a procedure. And these cycles basically just give that extra practice to reinforce a learning as it happens. So just to show you what the evidence behind this is, there's a couple different articles that I'm quoting here. Betsy Hunt trialed rapid cycle deliberate practice in resuscitation, and that showed that there was a 40% reduction in no flow time during CPR after RCDP SIMS as compared to non-RCDP SIMS, and also an almost 2 times higher chance of defibrillating within AHA recommended guidelines. So for something as high stakes as resuscitation, this has been shown to be useful. And it's also been looked at by Quarry and sepsis management. and showed that there was a significant improvement in checklist scores as opposed to standard education. Another study looked at this modality when applied to neonatal resuscitation. And again, it showed statistically significant increases in checklist scores and higher likelihood of timely positive pressure ventilation, epinephrine administration. These are just 3 representative examples. There's actually, as we speak, a number of systematic reviews. Some have come out already, some are being done on RCDP. And the general thought is that this is, for skill-based simulations, a very effective means of doing it, and probably more effective than the traditional model for, again, for isolated skills that really need to be honed to a fine point. So mastery learning, if RCDP is the do-over, mastery learning is drop and give me another 20. And so it has, mastery learning-based sims have the same structure as a rapid cycle limit practice, but the key there is that you add multiple iterations. You can initially see where this might be a problem in a lot of time-limited environments, but in an ideal world, the goal is to give us as many iterations as is needed to achieve a certain level of mastery. This might be 2 iterations. This might be 1 if you do it right up front. This might be 10. This really challenges our static idea of time-based instruction, with the goal being, if the learner knows it, let them demonstrate it and leave. If a learner doesn't know it, give them as much time as they need to get it. It is time consuming, but it is effective. And to really do this well, you have to know what a clear mastery standard is ahead of time. Now, one thing that's pretty critical about this, these mastery standards are that they should not be lowest common denominator. So, oftentimes we just could have defined competence as sort of a minimal bar that you have to pass. But this is not competence-based learning, this is mastery learning. And so the goal is to say, not what is the minimum, but what is the goal that you want everybody to pass for things to be done correctly. This is basically retaking the test and retaking the class until everybody gets an A, until everybody achieves sort of your top bar. And so in order to be able to do this, you have to have a way of measuring the skills of the individual in that session, so you know whether they've hit mastery, and you have to have a sense of what mastery of that skill truly is. But within those constraints, it's been shown to be very effective. A couple examples: Barsic et al. Looked at mastery learning to improve thoracentesis outcomes. There were fewer clinically meaningful pneumothoraces with a decent p-value, and so they were able to show actually that with thoracentesis, doing this really made a difference clinically. This isn't just in simulation, this is in patient practice. David Cook did a meta-analysis of mastery learning in 2013 and was able to come up with the following kind of synthesis statements. So compared to no education, mastery learning has a large effect in skills. There was 41 studies that looked at this. The effect size was pretty decently strong, 1.25, and it had a significant confidence interval. Looking at no education, mastery learning resulted in moderate effect on outcomes. And finally, compared with traditional sim, which is really the most useful one for an educator like myself, how does this stack up to normal simulation? It says that there was a large benefit in skills over the 3 studies that occurred with an effect size of 1.17. So while these are not like 3 or 4 times better, there's clear evidence that this mastery approach that does not let a learner leave the room until they get the skill and can demonstrate it makes a difference downstream in terms of patient care. The final iteration of simulation types that I'd like to look at is something called just-in-time training. And so what is just-in-time training? This is the idea of bringing kind of a last-minute training session to the learners themselves. So this would, again, involve a typical pre-briefing, but it would instead have a brief focus simulation, 5 to 10 minutes at max, performed within the clinical environment immediately before care with a brief feedback session afterwards. So this training has been used in a very effective way to inoculate people, or to give people basically a skills booster to something that they need to engage in, some skill that they need to enact basically right away. It brings it directly to the bedside. It chooses patients who are at a high risk of needing procedure or experiencing some specific outcomes. And the sessions are short to not really kind of impose too much of a strain on the clinical environment, and it has been shown to increase performance in those contexts. So one is Niles et al., who did just-in-time CPR training in a PICU setting. And in this study, providers practiced until they were able to perform CPR with less than 3 consecutive prompts within 30 seconds. So they added a bit of mastery learning there. But the key is this was at the bedside before they started their shift, with a targeted rate of 90 to 120 per minute and a depth of 38 during continuous CPR. And that just-in-time group achieved successful CPR in 46 seconds sooner. Now, that doesn't sound like a lot, but considering that PALS / ARC recommendations for starting CPR when an arrest occurs is to have it going within 10 seconds of loss of pulses. So that's actually almost 5 times faster. And that is not actually meaningless in terms of survival. Branzetti looked at just-in-time's transvenous pacemaker placement. And so this was a more complex procedure, but they showed that there was a significant improvement in technical skills checklist scores and a reduction in critical omissions in their ability to perform those tasks. And so before going any farther, that was sort of a whirlwind tour of different modes of simulation. And, in the last part of this, I'd like to talk a bit about how these might intersect with infection prevention. But I wanted to open it up for any questions about those modes of simulation and make sure that I was clear on sort of what is contained within them and what they can be used for. And I'll watch the chat. And if anyone has any questions, we can. Otherwise, I'll continue.
Hi, Dr. Calhoun. This is Sarah, one of the ID pharmacists. Not a question, but I did just want to make a comment, if that's all right.
Absolutely.
Sure. So I had seen this presentation when you gave it previously, and I did want to just share with you, and potentially it could be beneficial to the group, that we've implemented quite a bit of these strategies with some of our pharmacy residents. So especially like the just-in-time training, as well as some of the skills-based things. So responding to positive blood cultures and making therapeutic adjustments is one of the things that we have added to like their orientation. So I just thought that this was an excellent presentation the first time around, and I just wanted to share that it's definitely impacted how we've been teaching our adult learners here at Norton.
Oh, thank you very much. I really appreciate that. And actually, I'll say too, that might be something that I'd be interested in having you maybe communicate to the current director of the SIM program at the PEDS hospital, because I think these things can be implemented in many creative ways. And I think the Spark program would just love to hear about that. Yeah, I'd love for you to be able to hook up with Amy and, go over how you all are doing that, because I think that's really the kind of SIMs we should be doing.
Sure. Yeah, I'm happy to connect after this.
And I also want to illustrate one thing as well, is that the technology level is not the thing that matters the most. It's very easy to go into simulation thinking that you have to have these high-tech mannequins that have bells and whistles, you can put chest tubes in, all these immersive things. And at the end, at the beginning of the inception of this field, that's basically what people said. That's basically what people did. But now the idea is, as long as you can create an environment that is immersive enough for the skill that you're addressing, that may be all you need. So a great example, there was a study done in Tanzania. Some of the best studies of in situ simulation and just-in-time simulation have been coming out of Tanzania and sub-Saharan Africa. There's 2 programs in specific that these studies have looked at over multiple hospitals. One's called Helping Babies Breathe, and the other is called Helping Mothers Stop Bleeding, but they're both perinatal, neonatal style programs that use highly low-tech simulators. So the Helping Babies Breathe mannequin is basically a balloon that looks vaguely like a baby that you inflate with water. It's got a bulb that you squeeze, and it can give you the sense of kind of a pulsing umbilicus. And it has 2 very kind of rudimentary low-tech lungs that can be bagged via the bag mask ventilator provided. So a single mannequin plus the bag, can be purchased in that healthcare environment for about $5 to $10. That program has shown a very significant reduction in mortality when it's rolled out over an entire hospital setting. Probably one of the best examples of that I've seen. And so does the Helping Mothers Avoid Bleeding. And so this idea that the level of technology, that sim equals high tech, is really false. It can, if necessary, but some of the low tech interventions that you can do in short bursts across whole systems are some of the most effective in actually improving patient outcomes. Further comments and questions? I see chat clips there. Let's see. It's very interesting. How do we get this to the clinical educators to utilize? So what I'll say is that we actually have all these skills at Norton Children's kind of concentrated within our simulation program. It's the SPARK is the acronym, but we have the expertise in there to help anybody launch any of these initiatives that you would wish. Really, the only barrier to doing some of these things is training the clinician educators in how to do a sim, some of the basic ways of assuring buy-in, getting a sense of the needs of that unit, the skills you're trying to implement, and then probably most importantly, training in some of the debriefing techniques. I think that at the end of the day, debriefing technique is sort of a make it or break it feature. A lot of new debriefers phase into one or two camps. The first is, I'm going to tell you all the things you did right and wrong, and then we're going to leave. That just simply doesn't work. On the other side, you get sort of the vague, the excessively vague debriefer that says, so how did that event go? And then kind of has this hope that the team will lead themselves. And sometimes that's true. Sometimes they can, but many times they can't. And the teams that most often need extensive debriefing or extensive guidance are the ones that frankly can't do it on their own. And so that's why learning one of those methods for debriefing, one of those styles of asking questions can really kind of be the make it or break it thing when people are getting integrated. And even for just in time or some of these shorter situations, knowing how to ask the right questions at the debriefing to get people to reflect on their own skills, have those aha moments and say, oh, I got to get better at this, and feel that inward motivation to do it. That's really the key to the whole thing. But we have that expertise within the SIM program at Norton Children's. In case it's not out there, I am just going to put my email here. And if you're interested in exploring some of that resource, just email me and I will pass this on to the current director of the SIM program. I'm the senior advisor to it. And we can maybe find ways of integrating some of the activities you're doing into Spark, or sharing the expertise we have. But we have the knowledge within Norton Healthcare to make this happen. It's just a matter of finding champions. Debbie, I hope that answers your question. Further questions or thoughts? Well, let's go forward and talk a bit. This section is a little more kind of looking at the future about how some of these things could be done. And I'd like to just suggest some ideas I've had over the past year or two about how to engage simulation with infection prevention. It sounds like things like this are being offered in various ways, but I'm curious as to A, whether you're doing this, what you might be doing, or what you might be interested in doing in the future. So here's one example. Let's say that you have a hospital ward preparing for one or more highly infectious patients. I'm thinking back to the days when we thought we might, get a local Ebola outbreak, which is never out of the question, but not as much on the radar as it was back in 2014. I was actually part of some of that training to sort of get figure out how to do the donning and doffing of the PPE. And your problem is you want to assure appropriate PPE use. And so one way to do this, though, well, I should say in the past, ways people would typically do this is to simply train an entire floor of nurses or physicians, or both, ideally, to don and doff the PPE appropriately. And they demonstrate it to you and you assume they've got it. But skill decay is a very real thing. And if you do that training, if you do that training and it takes like 4 or 5 months for that patient to come in, and all of a sudden you need that skill right away, it's not going to be there. There's a lot of good studies looking at things as frequently educated as pediatric advanced life supports or neonatal life support that suggest that after that intensive 2-day class, if you haven't actually had to use the skill in real life, 6 months out, you're basically not that much better than you were before you took the class. And so developing an on-site in situ pre-shift refresher in how to do that using low-tech equipment, just having people actually do it under a situation where they have to do it with a relative sense of urgency and then debrief how it happened, can give you a booster shot of that skill to enable you to do it right in the moment. So that's one, I think, application that this could have for infection prevention. Now, how could you, got my Emerald shot here, how could you maybe advance that a bit? So other ways you might apply this is incorporating RCDP and mastery learning. This might not be doable in that brief inoculation period. It might be more doable in an initial training session where everyone has to demonstrate mastery in, again, donning and doffing that PPE. over multiple cycles. If somebody gets it right the first time, then great. If it takes them 10 times, then you stay there till they get it. And even better, by doing these things in situ, in the hospital itself, not in a conference room, but in the actual ward with the actual setup you'll be using, you also raise and add the capacity for detecting latent safety threats. For those that may not be familiar with that terminology, a latent safety threat is one that is present in how the environment is set up. It could cause patient or provider harm, but it hasn't yet. And so doing lots of rapid cycle and mastery learning training in the actual, say, ID unit environment, if there was something that was misplaced, or just the rooms were arranged in a way, or the PPE donning and doffing station were arranged in a way that made sense on paper, but in reality, nobody could actually use without, walking into a door and contaminating everything, you would find that out. And so you would not only be able to help learners gain the skill, but you would be able to run diagnostics on the environment that you set up to care for these patients. And again, none of this has to involve high fidelity mannequins or significant expense. So I had intended this to be kind of a short sort of refresher on sim training, throwing out some ideas that you may be familiar with from last time. But simulation-based education embraces a wide array of goals and approaches. The best approach is going to depend on the learning objectives, learner group, and available time. And the available evidence strongly supports using this really as we educate our learners and as we prepare for those low frequency but high acuity or high cost events. And there are ways of doing this that can be done cheaply, can be done with very little cost outlay, can be done with really what you have at hand. And so I mean this to sort of be an injection of empowerment to try these techniques. Again, I've left my email so that if any of you want to discuss this further or think about ways of engaging our existing simulation program in readying people to use some of these techniques in different ways, I look forward to those conversations. And I want to open it up for any discussion and a time for us to talk together and see how we might be able to apply these techniques in a way that helps us with infection prevention. I will stop sharing at the moment so we can, there we go. All right. Questions or thoughts?
This is Julia.
Hi, Julia.
How are you?
Good.
We are looking at doing simulation processes within the IP bootcamp that we're setting up in October for frontline healthcare workers, as well as infection preventionists and those in admin and other venues within healthcare. So I may reach out to you just to get ideas of ways that we can tailor those simulations to meet the needs of the audience that we're hoping to attract within that training. So is it okay if I?
Oh, sure.
Perfect. Great.
Yeah, please do. If I could ask though, I think it might be an interesting exercise to talk a little bit about like how that might work. So I don't know the degree of preparation, so I don't mean to put you on the spot, Julia, but is there a specific skill or problem that you're trying to solve with that you could kind of name right now? Because that might show a great example of how to think through this.
Yeah, so we've got it separated into 3 days, and days 1 and 2 would be the days that after the learning sessions, or I guess the classroom didactic style, then you would do the sim training. So day 1 simulations would be around the donning and doffing of personal protective equipment. First process being just putting it on correctly and taking it off correctly with no potential obvious contamination, and then redoing it, so putting it on and then doing some type of contamination, chocolate syrup, shaving cream, whatever. And then now that you've done it once, let's remove it again and see if we can successfully remove it without contaminating ourselves. How does that process look? How do you feel about that? We'll do one about hand hygiene. So with when to clean your hands with what, soap and water versus alcohol gel, when to wear gloves, how to take gloves on and off, and then cleaning and disinfecting of environments. So doing one where individuals are understanding how to clean and disinfect not only just the surface, but the equipment that's being used during general patient care. And this would be across all care continuum. So emergency services, long-term care, acute care. That's the plan for day one, at least.
That's really helpful. So I think that, let me talk maybe a bit about the first thing you threw out there, which is the donning and doffing. I would say that is perfect for a rapid cycle deliberate practice plus mastery learning. Like that's the approach. If you really wanted to get that, the best simulated way to do that would to do an RCDP with mastery learning style sim.
Okay.
And so like what that would involve would be coming up with sort of a clear, easy to look at, easy to assess sense of what mastering donning and doffing PPE means. You know, like something where somebody could watch somebody do it and say, if they do all these 9 things, they've got it in that environment. And then this is the hard part because education days are always kind of time limited. But ideally what you would want to do is have people, you know, you'd have a brief story. It'd be like a 5-minute, you got to go and see this patient. Here's what you're going to do. And then you'd watch it, and then people would just basically have to redo it until they get it right based on that predefined standard. And if you get it right sooner, then you're done. If you get it right not so fast, you just keep going until you do it. And you have to normalize that situation too. It's not like you're saying somebody's better than somebody else. It's just that this is a hard skill. Some might just be able to get there faster, and that's okay. The goal is that nobody leaves without the ability to do this well, so that all of us are on the same page. Everybody's equal in their capacity, and everybody has mastered this skill by the end of the day. I don't know how long you have to do the sims, but I think for something like donning and doffing PPE, you could make the actual sims short enough and the debriefings short enough that you could fit a lot into an hour or two until people can consistently demonstrate the skill. Does that kind of make sense?
Yeah, absolutely. We are planning to have about an hour and a half to do our sim our sim processes. And one hopeful advantage, right, is that everybody is at least familiar with personal protective equipment. They might not be proficient in it or know how to take it off and put it on correctly, but it isn't an entirely new product to them to even have.
The other thing I would wonder, and I think part of using sim well is knowing what sim is great for and knowing what sim is not as good for. And while I think incorporating like moments of hand washing into some sims could be good, that seems to, tell me if I'm wrong here, but that almost strikes me as more of a cognitive issue, like knowing when to do it. And I think if you had to focus your sim, I think if you're trying to get both skills maximized as high as possible, focusing a disproportionate amount of your sim on the physical activities of donning and doffing is probably going to get you more muscle memory at the end of the day than doing equal between them, if that kind of makes sense.
Yes, it does make sense.
Because I think sim is okay at getting ideas across. It's no worse than lecture. Right. It's no better. It's about the same, you know, especially in situ sims like you're talking about. What SCIM really excels at is teaching actual physical skills. So that's just kind of like maximizing each modality of education for the thing it's going to have the highest amount of delivery on.
Okay.
And I think if you had like too much time on the times to do hand washing sim, you might get a little boost from that, but you get a much greater boost from a significant RCDP with mastery learning skill on the donning and doffing. And so you might actually cut into that one too much. So those are just my initial thoughts on how that might work, but I'm happy to talk more.
Yeah, great. Thank you very much.
I would also say too, and this is kind of a general point again, if you're going for that RCDP plus mastery learning, you run the risk, if it's multiple people, of having some like finish early and then others finish late, even though that's what you need. And that emotional sort of, well, they got to leave earlier. And so setting clear expectations, like this is a skill you're all going to master before you go. And then normalizing that it takes some people a while to get, you know, everybody learns skills, different skills at different rates, so that nobody's feeling singled out, but everybody has a chance to practice till they have it. So psychological safety surrounding all this, so the event is seen as positive.
Great. Thank you.
But yeah, please reach out. I'm happy to go over more specifics.
Great. Thank you very much.
Oh, anytime. Other thoughts or questions?
All right, we might be tiptoeing just a little bit over, but that is perfect. I'm so happy that we had such great engagement today. So I just want to say thank you to Dr. Calhoun and his wonderful presentation. And I invite everybody back to Grand Rounds for next week, where Dr. Jenkins will be talking about a topic in microbiology. And again, if you have any questions that come up or arise after this meeting, please feel free to either email me and I can get you in contact with Dr. Calhoun, or please email Dr. Calhoun directly. Thanks, everybody.